Ravi will start, sir,
Ah,
and
okay,
second presentation will be mine.
Okay, fine. Very good evening and welcome to this session of controversies in neurology. Our apologies for these technical issues. Somehow, I think link got a bit of dysfunctional. Dr. Sanjay will join meanwhile we start. So today we are discussing a controversy on the headache, and there is a interesting topic which sometimes produces clinical challenge regarding trigeminal neuralgia, and other is trigeminal autonomic cephalgia with specific features of SUNCT and SUNA, whether they are the same disorder or same spectrum or they are different disorders. So we have two eminent speakers who will be speaking on these different aspects. And then we have a panel discussion. Eminent headache expert Dr. Ravi Shankar sir is with us. So, and I hope that Dr. Sanjay will be able to join. So I welcome all the speakers and all the delegates, and I will request Ravi to start his part of the debate.
I cannot start. Good evening, sir.
Yeah, Ravi.
Yes, sir. I'm just. Good evening, respected Rathod, sir.
There is some problem in your.
Sir, am I audible?
You are audible, but there is some echo. The support team, can you look into it? Or I'll request.
Yes, sir. Sir, have you kept your device near to the other device? Can you please keep your device away so that it doesn't echo?
Sir, is now clear?
Better than before?
Yeah, it is clear, sir. You can switch off the audio of one device. Yeah.
Okay.
Okay, Ravi, you can make a power slideshow and then start.
Sir, is my screen is visible?
Yes, visible, and you are quite audible. So please go ahead.
Okay, thank you, sir. Thank you, Rathod, sir. First of all, good evening, Ravi Shankar, sir, Rathod, sir, Paliwal, sir, and all the eminent faculties and audience, and my dear colleagues. Today's topic is whether SUNCT and trigeminal neuralgia are two distinct disorders or they are actually the two manifestations of a single disorder. Before I put my arguments on the favor of the notion that these are actually two distinct disorders, the first thing which appears is why this question is actually arising. Why we are thinking that they are whether two disorders or this is two manifestations of one single disorder. So this is because of the both of them actually present with short-lasting episodes of facial pain, and which is of few seconds duration, sometimes few minutes duration. And the character is also similar, like both have sharp, severe, and lancerating pain. So because of this similarity, this question is arising. But here I want to emphasize that however similar the two disorders may be, but if there are some characteristics with which we can distinguish them, and we have some basic pathophysiology to explain their clinical manifestations, then probably we are dealing with two different distinct disorders. Considering this as the basis, I am saying that these two disorders are actually two distinct disorders because they have distinguishable clinical characteristics and they have different pathophysiologies to explain their symptomatology. So for that, my first point is that these both disorders are placed at different places in the classification system. This is the ICHD-3, International Classification of Headache Disorders, 3rd edition. And we can see here that SUNCT is placed in the group of trigeminal autonomic cephalalgias, which is a primary headache disorder. And on the other hand, trigeminal neuralgia is placed in the group of painful cranial neuropathies, which is actually a nerve disorder. So they are actually placed in different places because they are different disorders. The next thing which I want to say is they both have different clinical manifestations in form of presence or absence of autonomic features. As we know, the SUNCT in the SUNCT, C denotes for conjunctival injection and T denotes for tearing. That means SUNCT is defined by cranial autonomic features, and they are not the just features. There are even other features like ptosis, nasal congestion, like facial flushing. These other features may also be there. On the other hand, trigeminal neuralgia is considered as a dry condition, and these autonomic features are really rare in this condition. So on the basis of presence or absence of autonomic features, we can differentiate both the conditions. Another point is location of the pain. Although both of these disorders present with facial pain on the one half of the face, but still they have a different location of the pain. In SUNCT, this is usually the V1 distribution, and on the other hand, in trigeminal neuralgia, this is usually the V2 or V3 distribution. So on the basis of location of pain, we can differentiate between the two disorders. The next thing is triggerability and spontaneous pain attacks. In trigeminal neuralgia, all the patients report triggerability. Triggerability means they develop or pain attacks just by some innocuous stimuli, just like chewing, just like touching their face or eating or washing their face. Such innocuous stimuli can precipitate the attacks in trigeminal neuralgia patients. On the other hand, this triggerability is not that common in SUNCT patients. On the contrary, SUNCT patients usually report spontaneous attacks. And on the contrary, in trigeminal neuralgia, these spontaneous pain attacks are a rarity. So there is difference in this manifestation also. The next thing is presence of refractory period. What happens in trigeminal neuralgia when one pain attack is happening or triggered, after that there is a few seconds or minutes gap, and that gap is called refractory period, in which there is new pain cannot be triggered by any stimuli. So this is called refractory period, and this is classically seen in trigeminal neuralgia. This can be seen in SUNCT, but this is a rare phenomena in SUNCT patients. So the next thing is drug responsiveness. Carbamazepine has very wonderful effect in trigeminal neuralgia, but in SUNCT, the effect of carbamazepine is only partial, and the effect of carbamazepine is trigeminal neuralgia is so specific and so clear that some people actually use this as a clinical hint for the diagnosis. And on the other hand, in SUNCT patients, the effect of carbamazepine is not that good, and the drug of choice is actually lamotrigine for these patients. So the treatment of both conditions are different. The next and most important thing is difference in the pathophysiology. As I earlier said, that SUNCT belongs to the group of cephalalgias, and trigeminal neuralgia belongs to the group of neuralgias. So SUNCT is a primary brain disorder. On the other hand, trigeminal neuralgia is basically a nerve disorder. So there is difference in the basic pathophysiology in both the disorders. If you look at the pathophysiology of SUNCT, the main pathophysiology is considered as the activation of posterior hypothalamus, which leads to disinhibition of trigeminal autonomic reflex, which can explain the phenomena of cranial autonomic features in these patients. On the other hand, the main pathology in trigeminal neuralgia is considered as the compression of root entry zone. Root entry zone is a very vulnerable area because there is transition of peripheral myelin to the central myelin. Because of this, whenever there is any compression happens in this specific area, this leads to microvascular ischemic damage. And this can start a process of focal demyelination and remyelination. And this further leads to lower excitatory threshold of affected fibers. And this leads to effective transmission between the adjacent fibers. And because of this, actually, because of this effective transmission, the fast conducting fibers, the A beta fibers, are connected with the A delta fibers, the slow conducting pain fibers. So stimulation of touch fibers can lead to generation of paroxysms of pain in these patients. So there is difference in the pathophysiology. And when we get the MRI of these patients, in SUNCT patients, MRI is usually normal. However, sometimes there may be abnormality, but largely it is normal in SUNCT patients. However, in classical trigeminal neuralgia, the finding of a artery or a vein or any arteriovenous malformation compressing that route is almost in every case is there. So there's difference in the neuroimaging in these patients. Now we come to the difference in functional MRI. Some people have done the functional MRI in these patients. This is the functional MRI of a SUNCT patient, and we can see that there is activation of the posterior hypothalamus, which is considered as the hallmark or trigger of the SUNCT in these patients. On the contrary, this is the functional MRI of trigeminal neuralgia patients. Panel A is actually for while the pain was triggered, and panel B is when there was no pain. In both the conditions, we can see that there is activation of primary and secondary sensory cortex. And at the time of pain, there is further activation of spinal nucleus of trigeminal nerve, brainstem, thalamus, and anterior cingulate cortex, insula. They all structures are actually related with the pain pathway. So there is difference in the functional MRI in both the conditions. Now I want to show that I was talking about the clinical features. I am showing the picture of two patients, and we can clearly differentiate just by seeing them, the difference in the SUNCT and the trigeminal neuralgia. In this picture, we can see that the patient is having ptosis, the tearing is apparent, and there is conjunctival injection. So we clearly know that this patient is of SUNCT. And on the other hand, this is the photograph of a patient who is suffering from trigeminal neuralgia. And we can see that this patient, the right half of this patient, there are some blackish spots, and these blackish spots are actually mud. The patient had so much triggerability that he could not wash his face for last around 3 to 4 months. And because of that, he did not wash his right half of the face. The mud was collected. And when we got his MRI, we were able to see the vessel compressing the right cranial, right trigeminal nerve root. And when we gave this patient treatment, of course, the carbamazepine was given, but in little higher doses, and the patient was able to wash his face and he was able to even shave his face. So here I want to emphasize that these both disorders have distinct clinical features. They have distinct pathophysiology to explain their symptomatology. So they are quite distinct disorders. With this, I want to stop here, and thank you very much for patient listening. Over to Chaturbhuj sir. Sir, you are not audible, sir. Chaturbhuj sir, you are not audible, sir.
I think Sanjay is joining, so we will just wait if he's join up for the panel discussion. Meanwhile, Ravi very well presented, and you gave your points. I will now request Vimal to present his point of view and suggesting that both are probably the same spectrum of disorders. So Ravi, you can stop sharing your screen, and Vimal will probably can start.
Am I audible?
Yes, Sanjay bhai, you have joined, so you are audible now. So you can take over now.
Recording in progress.
Hello.
Hello, good evening to all the panelists. Good evening, Sanjay Bas.
Good evening.
Can I start my video? I'm not been able to start.
Yeah, you can
video.
go.
Good evening to all the panelists and all the delegates. So, am I audible?
Yes,
Yeah,
yes,
you are
Vimal,
audible.
we
Okay,
can see your screen and you are audible. Please go ahead.
Thank you. Yeah. So, Ravi has very beautifully presented why SUNCT and trigeminal neuralgia should be considered separate disorders. Because this is the truth till date because the literature supports so. So, I have an alternative idea, and this is not only me, many of the people who have been working in this SUNCT syndrome have also reflected similarly in recent times. So I'll start with the the hypothesis that SUNCT and trigeminal neuralgias are similar disorders. Rather, they might have been representing a spectrum where the least severe part is trigeminal neuralgia and the most severe part would be SUNCT disorder. So before I go into my presentation, I would request all of you just to recollect how many patients of trigeminal neuralgia V1 distribution have you seen. So if you try to recollect, you will not be able to remember many. The reason is V1 trigeminal neuralgia is very rare. And whenever it occurs with autonomic symptoms. And those I think have been categorized as either SUNA or SUNCT. So if we go into the criteria of SUNCT disorders, so they are characterized by short stabs of pain, which may be single stabs, multiple stabs, or a sawtooth pattern, and headache or the pain lasting only few seconds, up to 600 seconds, associated with a number of autonomic symptoms. And this the number of attacks per day can vary from one to several, up to hundreds of attacks a person can have in a day. Now they have further divided this into SUNCT and SUNA depending upon the number of autonomic symptoms a patient is having. If a person is having conjunctival injection and tearing both, it may be classified as SUNCT. Or if person has only one of them or none of them, but with the presence of others that are listed here, then they may be categorized as SUNA. And if you see here, the triggering of attacks in SUNCT and SUNA, and now you again try to recollect the trigeminal neuralgia that you might have seen in your clinical practice, you will see that all the triggers that trigger SUNCT and SUNA are also the triggers of trigeminal neuralgia. And as far as etiology is concerned, there we all now agree that most of the patients with SUNCT and SUNA now, if they are properly scanned with proper images of MRI, most of them will be able, you will be able to see a vascular loop compressing the trigeminal nerve on one side or on both sides. Now, if you see the criteria of trigeminal neuralgia, the phenotype is almost similar. The pain is of shock-like, shooting, stabbing, or sharp in quality, multiple attacks per day, and they can be precipitated spontaneously or by innocuous stimuli. The number of stimuli I have already mentioned. They are same as that are mentioned in SUNCT and SUNA. The other features are autonomic features. Now, we don't talk much about autonomic features in trigeminal neuralgia. The reason is V1TN is very rare. So whenever you see V1TN, around 40% of those who have been categorized as trigeminal neuralgia will have autonomic symptoms, one or more than one. They can have other features like contraction of muscles, which may be categorized as stick dolorux. And you will find the neurovascular compression at root entry zone in majority of the patients with classical trigeminal neuralgia. Now, these are the similarities between SUNCT and trigeminal neuralgias. Both are short-lasting. Both have single or multiple jabs of pain. Both can have triggered and spontaneous attacks. Both have autonomic symptoms. Now, both of them have vascular loops at root entry of trigeminal nerve. And now there is sufficient literature that both of them improves with decompression, trigeminal nerve decompression surgeries, which are microvascular surgeries. Now, this is our patient of SUNCT, which is showing a vascular loop around the trigeminal nerve. This is another patient which is showing a ectatic this vertebral artery in the vicinity of right fifth nerve. The differences between SUNCT and trigeminal neuralgia is very superficial. This is SUNCT is the commonest is V1 distribution. This commonest in SUNCT because this is rare in TN. So all those TN V1 are actually SUNCT. Choice of lamotrigine is because the lamotrigine has never been tried in trigeminal neuralgia. If you see and recollect your own prescriptions of those who are either SUNCT or who are refractory to trigeminal neuralgia, you will find all the drugs being prescribed to them, including carbamazepine, oxcarbazepine, lamotrigine, and gabapentin. Most of these people will be having multiple of these anti-epileptic drugs. Now, the issue was that the SUNCT is said to have no refractory period, while trigeminal neuralgia is said to have a refractory period. Ravi has beautifully described what is a refractory period. During the decrescendo phase of a SUNCT attack, ongoing SUNCT attack, or even immediately after the attack has subsided, if you stimulate or you trigger attack, you will be able to trigger SUNCT as many times as you trigger. But this will not be possible in case of trigeminal neuralgia. This has been a issue of contention among the headache experts. The people say that 5% in SUNCT and 11% SUNA patients have refractory period. Others won't have a refractory period. Now, see, this is one of our patients of SUNCT syndrome. So he is having an ongoing attack on right side. Now you can see that there are multiple jabs of attacks, pains. Just you can make it out just through the expressions of the face. And there is lacrimation on right side. You can see right eye is smaller than the left eye because of ptosis, mild ptosis, and there is redness on the right side. Now the attack has subsided at this point. Now I'll request this person to again trigger. Now he's trying to trigger the attack the way he triggered the first attack. Now I requested him to try hard. He's trying again many other methods by which he usually has his attacks triggered. He's opening his mouth and doing many other things. But there will be no recurrence of attack. Now, surprisingly, what I have seen in my patient with SUNCT, the refractory period is absent, but refractory period is variable. At some times, refractory period is there, and at other times, it is not there. And this is the situation when this patient was relatively treatment naive. So what I believe is, what the current position of ICHD3 is, that they classify a larger picture as SUNA, where the patient has a paroxysmal periorbital attacks with autonomic features. A small part of it is SUNCT, where the autonomic features are very severe. And they have categorized trigeminal neuralgia not as a part of TAG, but as a part of a neurogenic pains. I think what we propose here is that the larger picture is that of a trigeminal neuralgia, because now we know that SUNCT and SUNA can also involve V2 and V3 distribution. Trigeminal neuralgia may or may not have autonomic features, but just for the sake of clarity, we can say that if there is a V1 attack without autonomic features, it may be categorized as trigeminal neuralgia. If has a mild autonomic feature, it may be categorized as SUNA. And if there is a subset of patient, which is usually small one, which has a very severe autonomic attacks, then it may be categorized as SUNCT. I have not prepared a slide of pathophysiology, but Ravi described the pathophysiology of SUNCT and SUNA as the disinhibition of the trigeminal autonomic pathway because of the stimulation of ventromedial hypothalamus. Now the issue is ventromedial hypothalamus stimulation can only explain autonomic features. It is not the pathophysiology behind the pain. Pathophysiology of the pain both in SUNCT, SUNA as well as in trigeminal neuralgia is only haptic transmission among the fibers of the fifth nerve. It is only when it is disinhibited there are autonomic symptoms, and I believe that we have not sufficiently looked into the functional imaging of trigeminal neuralgia as in V2, V3 distribution also. So we are not actually in a position to comment whether this is a unique phenomena for SUNCT and SUNA only and not for trigeminal neuralgia. So to conclude, I think that SUNCT, SUNA and TN, V1, TN are rare. There are no actually clear pathophysiological divide. What we know is that they occur because of ephaptic transmission, and autonomic symptoms in either of the situation will occur if there is a the stimulation of ventromedial hypothalamus. They share common causes and common therapeutic options. Refractory period, we have shown there is not a reliable differentiating feature between the two. And what I believe and what many others believe that SUNCT, SUNA and TN may represent rather a continuum rather than a separate entities. Thank you so much.
Thank you, Vimal, for your nice presentations. And first of all, I am sorry that I could not join earlier. I am audible. Can you hear you all?
Yes, sir.
Yes. So I missed the earlier part, and first of all, I thank Dr. Ravi Shankar sir. Despite being the ill, he is here. Sir, can you sir hear me, Dr. Ravi Shankar sir?
Good evening, sir.
Good evening.
Good
Yes,
evening, sir.
yes.
Sorry, sir, I
all of
was
you.
not there.
Good
No
evening,
problem.
sir.
So after this, sir, two lecture, your take on this part, sir.
Okay. First of all, let me say that you have called me to give my expert opinion, but I have learned a lot by listening to both the speakers. And when you set up this debate, I'm sure, Sanjay, you yourself knew that this is going to be an academic divide, because when we are faced with these patients in practice, particularly this is commonly a tertiary headache clinic problem, much more than what general neurologists would try to tease the situation and try to find a divide. The problem always starts, at least for me, these are two rare conditions, the SUNCT and SUNA, and trigeminal neuralgia with lacrimation. So the problem really starts when there is lacrimation. And the degree of lacrimation, there are many aspects to these two entities, which are for me so difficult to evaluate in practice that I really admire the pundits who have written large papers, large case series, where they have looked into the pattern of the attacks and gone on to describe stabs, groups of stabs, and sawtooth pattern, and even the evaluation of the refractory period. It is not an easy thing in practice because many of our patients are not educated to that degree as in the Western world. So to find the differentiating points and then come to a conclusion. So what happens in practice, at least in my experience, is both patients, either whether they are SUNCT or SUNA or TN with lacrimation, are tried out or are going through a therapeutic trial of the overlap drugs. And finally, we strike gold with one of these drugs, and then that is what leads to the diagnosis in retrospect. But by and large, the degree of autonomic features, and there are so many things which I still don't understand why they have tried to divide SUNCT and SUNA. Now, I like the first talk by this thing where he just used SUNCT. He did not get into SUNA, because when you talk of both being present, one or none, and then you forget entirely. Even let us talk, Sanjay, I'd like to know your experience also. The other autonomic symptoms which people are talking about, which are listed so beautifully in the criteria. Now, how often have you seen facial sweating, facial flushing, fullness in the ear, and all these other autonomic features? And they have chosen to highlight the two most prominent, conjunctival ingestion and lacrimation. They have even not chosen or used rhinorrhea, which is more common with what we see in cluster headache. Here
Yes,
you
sir.
rarely see the other autonomic features. And even when you just see the patient with all that amount of edema, with all the amount of conjunctival ingestion, SUNCT strikes you in the face, because we are debating between V1TN and
Yes, sir.
SUNCT, and I have found it difficult to even divide between SUNCT and SUNA. So these are attractive terminologies, attractive diagnosis to make, and many clinicians, many students would jump at the diagnosis of SUNCT and like to call every TN with lacrimation SUNCT, because SUNCT is more fashionable than calling it TN. But if you go through the literature, and the older literature talks of TN with lacrimation starting from the time of Gowers and others. But in practice, how often would a general neurologist see TN with lacrimation? Not so common at all. Like was mentioned, V1TN is by itself rare. But given V1TN also the degree of lacrimation, that's a deciding factor. See, apart from the functional MRI showing the posterior hypothalamic activation, we don't do functional MRI in most of our setups. So we have to go clinical. We are all going to do MRIs. We are all going to rule out secondary causes. We are all going to look for neurovascular conflicts. but the degree of overlap is so huge that it is difficult for me to say without functional MRI whether it is a continuum or distinct disorders. But at this point of time, with all the without the fMRI, I would like to think that they are separate disorders. And TN with lacrimation is because of the transformation. Also, people tend to get confused. Cases do transform, cases do have overlaps. You have cluster takes, you have pH takes, you have TSE and take overlapping. So the transformation, the overlaps can all be understood. But at this point of time, if you ask me to pitch in one direction, I would say that they should be looked upon as distinct disorders rather than SUNCT being looked upon as a neuralgic disorder. So your thoughts, Sanjay?
Sir, thank you for your opinion, sir. But there are, sir, a few questions I would like to know from your side. There are several studies, sir. We have also reported that there are no much difference between SUNCT and SUNA, and in near future it may be merged together. But sir, there are several studies that suggest that even trigeminal neuralgia is not different. Even sir, few studies have demonstrated that carbamazepine and oxcarbazepine may work even in SUNCT and SUNA. So how do you see that this response? Initially, it was an important point. The response is of carbamazepine is there, then we used to make it as a trigeminal neuralgia. But it is one of the important drugs. Second choice of is the carbamazepine and oxcarbazepine for SUNCT and SUNA. So how do you see this response of carbamazepine and oxcarbazepine in SUNCT and SUNA?
See, now there is a central originating posterior hypothalamic element. There is also a peripheral trigeminal element involved in these SUNHAs, as you would like to call it. That includes both SUNCT and SUNA. And these are responsive more with sodium channel blockers. And all these drugs, they are broad spectrum. You cannot, because see, there is definitely a neuropathic element. But then you look at the absence of a sensory deficit in SUNCT and SUNAs and the presence of a possible sensory deficit in a trigeminal neuralgia-like situation in some cases. Then the presence or absence of a background pain and these elements. So the action of carbamazepine does not be the deciding factor for this, the premise of the debate. It is a point which is to be used, but you cannot use it to justify one way or the other, because at the end of the day, one could argue that both the speakers have justified their way of looking at the issue. But you cannot use the action, because 40% of SUNCT and SUNA would respond with carbamazepine also, which is a large number. So
Yes,
because there is a peripheral element to the pathophysiology, I think the trigeminal component is acted upon by the carbamazepine, and so therefore you find that they respond. But there are better drugs. Why do the better drugs work only in SUNHAs, and why does lamotrigine not work so well? Now, lamotrigine is also used in trigeminal neuralgia as a last bit add-on. So you could pitch that lamotrigine is also used here. So gabapentin is also used in both the places. So everything except the functional MRI, there is overlap in both these entities. Neurovascular conflict was not seen much before. Now, in the last 5 years, you see that treatment is microvascular decompression for SUNCT also. So overlap is very huge.
Okay, thank you, sir. So one question, Bimal, for you, as you consider it is a different phenotype. So do you get confused when you make a diagnosis of SUNCT or trigeminal neuralgia? How many times you remain sure that it is trigeminal neuralgia or you are dealing with SUNCT? So what are your point that it is really SUNCT and it is really trigeminal neuralgia? Is there any point
No,
that is specific?
I have relatively more clarity, sir. The reason is that I think that all those V1 trigeminal neuralgias are all SUNAs. what happens is, if you follow these patients closely, the number of autonomic features and the severity of features and severity of attack actually varies over a period of time. So they will be reverberating between the pure TN where the autonomic symptoms are not there, and at some other times they'll come up with very severe autonomic features while on treatment. So I think that this is a ongoing continuum even in a given single patient also. So it is only that the V1 was rare. It was probably classified at some point of time as SUNCT or SUNA, I think. And the other thing is that the trigeminal neuralgia is also not a monolithic entity. It has also got two forms. One is a classical trigeminal neuralgia and the other is atypical trigeminal neuralgia. And around 40% of TN are atypical, whereby they have a background pain. And on the background pain, they have a sawtooth or a jabs of pain. And these are the more so of those patients who have autonomic phenomena. So I think at some point, people have diagnosed SUNCT SUNA among these patients. Even if you name them separately, I don't have any problems with it. But then the phenotypics, we should be very clear. You can call trigeminal neuralgia as trigeminal neuralgia when they don't have any autonomic features. And we call all those who have lacrimation or redness or any combination as SUNAs. But then we should not say that 40% of TN has autonomic features. We should say that those who don't have autonomic features should be called trigeminal neuralgia. No problem with that. At least we should be phenotypically clear. Because at the present time, there is no pathophysiological divide because we have not sufficiently used FMR in patients with trigeminal neuralgias. That is my take on that.
Okay. Some patient, especially trigeminal neuralgia, is it also called as tic dolorix. Patient wins and shows some movement, aversive head movement. So sudden severe, very severe pain. So some aversive, that's why it is called as tic. Do you think it is more severe than SUNCT and SUNA, and that's why it is different?
Sir, if you see
Severity of the
patients
pain
with
is so that there is some aversive movement. Typical patient will wince and there will he will catch the aching part.
Sir, if you see the patients with SUNCT ongoing attack, one of them I showed. There are many other videos also with me. If you see the peak of their attacks, they'll not be able to open that eye where the pain is. That eye will be forcefully closed. There will be contraction of all the facial muscles on that side. And that is actually a tic dolorux, which occurs in both in severe attacks of trigeminal neuralgia, maybe V2, V3, where you won't find any autonomic features in the eye or may find a little bit of that. But in all patients of SUNCT, you will find that phenomena of facial grimacing on that side because of severe pain.
Unyal, I would like to know from your side. So there are trigger in both cases. Do you find any differences in trigger of that SUNCT and SUNA versus trigeminal neuralgia? Can we get some help in differentiating, as you are considering it as a different disorder? But there are overlap in triggers. But is there any difference with that triggers?
Sir, although I have presented like they both are distinct disorders, but in reality, in practice, this is very difficult to differentiate them, and especially triggers, because I have seen many patients along with Palival sir, SUNCT patients, and in almost every patient we found triggers. So in literature, it is written that triggers are not there in SUNCT that much, but in reality, I don't remember any patient of SUNCT who did not report triggers. So I think triggers are actually present in both the patients, and it is very difficult to differentiate on the basis of triggers both patients. However, the presence of autonomic features is so profound in SUNCT patients that it tells you over your face that it's SUNCT. Because when you see the lid edema, the conjunctival redness, the tearing, you know that it's SUNCT. It cannot be anything else. But when it comes to triggers, they are present in both the conditions, sir.
Oh, I would like to from Dr. Ravi Shankar sir about the trigger, sir, because 1/3, 1/4, half of the patient in some study have demonstrated a spontaneous attack could be more common than SUNCT and SUNA, sir. How do you think, sir? A spontaneous attack more common.
Now, one question which we need to put down on the table right at the outset is, these being such rare disorders, let me know from each one of you how many patients each one of us has seen with this dilemma of being unable to differentiate between SUNCT forget SUNA, because I really don't respect too much of going into the division between SUNCT and SUNA, because at the end of the day, the treatment is the same, whether it is SUNCT or SUNA. So at least let us use the category of SUNHAS, that is the short-lasting headaches, and trigeminal neuralgia with lacrimation. So with a hand on your heart, please tell me how many patients has each one of us seen, and how many patients have you been at the outset been able to differentiate as SUNCT? Because the way I think it was Ravi who mentioned that the patients at the outset itself, you can make out that this is SUNCT by the degree of eyelid edema, by the degree of conjunctival injection. So it's not the degree of pain. So can we just hear from each one of you how many patients have posed a dilemma? Because this would be a headache specialist dilemma, much more than a general neurologist dilemma. So Vimal, how many patients in your experience would you have seen?
Sir, a very nice question, sir. Actually, many years back, I presented 3 patients where there was no refractory period.
I read
At
that.
that time, there was a proposal for ICHD3 that the refractory period should be considered as a diagnostic criteria, and probably somehow that stalled after that. I don't know whether that paper was contributory or not, but it happened so. After that, I saw many patients, but somehow I lost interest in SUNCT, so now I stopped collecting. If any of my residents is in participants, at the present time, he can tell how many patients, because we see it very often. No, I don't find any difference. I feel that all these patients are patients of trigeminal neuralgia only, sir, who have varying degree of autonomic symptoms. So I don't go into the debate as whether they are SUNCT or trigeminal neuralgia. We treat them as TN only, and we offer the same drugs to all these patients. Number I won't be able to tell you, because I have not been keeping record of these patients.
So how
lately for
often do
last.
you use lamotrigine?
Sir, we use lamotrigine very often, both in trigeminal neuralgia and SUNCT. And the reason is that we don't get trigeminal neuralgia who are treatable with a single drug in our center. We get
But why
only those who are.
lamotrigine? Why lamotrigine for
Sir,
trigeminal neuralgia?
Sir, that is what I am trying to tell you, sir. We see trigeminal neuralgia only those patients who are referred because of their refractoriness to treatment. They're already on number of drugs, so we do add lamotrigine in these patients. They're already on 2 or 3 anti-epileptics prior to reporting to us. We don't see patients of trigeminal neuralgia de
So
novo.
do you add lamotrigine because you're thinking of the possibility of SUNCT in these patients? Or
No,
do you
sir.
add lamotrigine
No,
for
sir.
trigeminal neuralgia per se?
Sir, lamotrigine is a wonderful drug for all neuropathic pains. If you try lamotrigine in patients with neuropathic pains, it will produce wonderful results. If somebody is having neuropathic pains in extremities, lamotrigine, I think, is the first drug choice for them. It's such a beautiful drug for neuropathic pain. It similarly works in trigeminal neuralgia as well as in SUNCT.
Because it's the dividing drug of choice between SUNCT and trigeminal neuralgia. To go
Sir, I think this is also very superficial.
If you see all the literature, see, now you're going with your impression, but if you see the literature, to differentiate between a TSC and trigeminal neuralgia or SUNCT, they tell you give a therapeutic trial with indomethacin or oxygen. That is besides the point, because clinically itself, we don't need to use indomethacin or oxygen. But once you have crossed that stage and you're going to a higher level where the debate of today is the thin line between SUNCT and trigeminal neuralgia with lacrimation, V1. We are clearly talking of V1 lacrimation. Yes, then sir, my dilemma is, yes, let me finish. My dilemma is, I don't still know. I don't use a stopwatch. I don't still know how to evaluate the duration of the attack to perfection, whether it's 2 minutes or 10 minutes. Second is, I do not know how to evaluate. That's why I said, I have come today to learn. I do not know how to describe a sawtooth pattern in the type of paper which Anna Cohen has written with the diagram. How to describe a sawtooth pattern in that speed of the attack, and the patient is in misery. The third is, you have written an excellent paper with 3 patients whose refractory period, about the refractory period. Now, I still, in some cases, unless the gap is really significant, If they are close attacks, it is difficult to say whether or not there is a refractory period or not. So therefore, because the clinical observations, because the degree of autonomic manifestations is another thing which literature talks about. Mild autonomic involvement, severe autonomic involvement. So the degree of autonomic activation is another finer point, which a person like Shastad or Godsby can, with 5 postgraduate students looking at each aspect, I can understand that they would be able to. But in routine clinical practice, how do you get hold of these points? So therefore, we go on to the use of drugs like lamotrigine, topiramate, gabapentin. If they work and you have a overlapping clinical presentation, you call it SUNCT. If carbamazepine works and you have a milder form of autonomic activation, you call it TN with V1 lacrimation. So that is the way I think I would approach. But hats off to you if you're able to identify all these points. So tell me clinically, how many
sir.
of these points you're able to evaluate?
Okay, sir. Sir, whatever you are saying, I completely agree with you. What this was actually what I was debating about. I want to tell you that the trigeminal neuralgia and SUNCT are a spectrum, whereby a SUNCT represents the most severe form of the disease. That is why the drug of choice could be lamotrigine, whereby most of the trigeminal neuralgia will respond to oxcarbazepine or carbamazepine. That goes with actually my opinion only. Second point is, sir, the sawtooth pattern and the refractory period. Refractory period, I don't believe after seeing so many patients that this is differentiating only. Again, it goes back to the severity of the disease, because SUNCT are so severe, they are having hundreds of attacks per day. So they may have a time where there is no refractory period in SUNCT. Trigeminal neuralgia represents the least of the spectrum of the disease. So they
But
are
can you
bound to have.
evaluate refractory period?
So it is very easy. The way I showed this in this video, similarly, every patient can be seen for refractory period. It's very easy.
Refractory
And
period
about
for how long?
With numerous attacks?
with
And the
numerous
attacks are
attacks, sir.
frequent?
After each attack, whatever you are able to witness at that particular point of time, you ask the patient to just trigger the attack during the decrescendo phase of the attack, or after the attack has just subsided. In SUNCT, sometimes the patient that I showed where there is ectatic vertebral artery, this patient was already on 4 or 5 drugs when he came to me as trigeminal neuralgia. He was having such a severe pain that he was not having there was complete absence of refractory period in this particular patient. But when we started treating him, his attacks came down, severity of disease came down, so there was refractory period. He was hardly having 5-6 attacks per day.
And how do you
So,
rate the degree of autonomic activation, whether it's mild, moderate, or severe?
so it is just by the number of autonomic features a person is having.
So what
Again,
all
I
do you
think,
see beyond conjunctival injection and tearing?
sir, the patient
Do
I
you
just
see the
showed,
forehead and facial sweating?
sir, facial sweating is rarest of them. This is what I believe.
Fullness in the
Rhinorrhea
ear?
is rather more common.
Fullness
Ptosis
in
is,
the ear?
sir, that I have not seen in many patients. Fullness in ear. That you mentioned rightly, that is more common with other attacks.
Sanjay,
Okay.
your opinion?
Okay, sir. So yes, that's why there is a lot of controversy. That's why there is a debate. So definitely, sir, there are not one symptom sign here. It is the group of symptom sign that probably differentiates, sir. There are 4-5 points are there. So that 3, 4, 5 are one side, then we can say. So one of the, sir, point is the important point is that in recent criteria in ICSD, they have a attack duration. They have for SUNCT and SUNA made up to 10 minutes. So is it duration little bit helpful in differentiating trigeminal neuralgia versus
Definitely.
SUNCT and SUNA? As you are
But-
considering it as a different disorder.
Yeah, but the 10-minute which they have expanded, and in fact, that's another thing. See, when they use seconds, one tends to think these are short attacks, but 10 minutes is a long period. So I don't think these SUNCT, I have not seen the such a long duration severity of attack in SUNCT patients. So the duration is also confusing because trigeminal is sharper, shorter, in my opinion, but and SUNCT is longer, but up to 10 minutes I have not seen. So I don't know if Vimal has seen 10 minutes. Would you agree with that duration?
Not at
Review
all,
of the
sir. I've
literature
never seen
suggests
10 minutes.
just a question. Review of the literature suggests that trigeminal neuralgia, one attack may persist for 5 to 6 seconds. It is the mean or median, and rarely up to 20 seconds. But in ICSD, they have mentioned up to 2 minutes. But most of the attack probably in trigeminal neuralgia is about 5 to 15
I
seconds,
agree.
and in SUNCT and SUNA more than 1 minute. So
I
I
agree.
think that could be one of the differentiating point. But again, there is not any stopwatch, so we can't just believe on the patient parts. Dr. Ajay have also joined here, so I will ask Dr. Ajay about his opinion on SUNCT and SUNA. What do you think, as a separate disease entity or same? Dr.
Most
Ajay.
likely both are, good evening, sir. Most likely, in my opinion, both are separate entity because in SUNCT and SUNA also there are some vascular component is autonomic dysfunction involving vascular component is also there, such as although rare, yeah, uncommon, or orbital phlebography such as vessels and fluctuation in blood pressure, forehead sweating, intraocular pressure. These are also increased in SUNCT. So there is some definite involvement of the vascular system, autonomic system, in which other than nerves, there are some vascular component is also there, which is usually not present in the trigeminal neuralgia. So I think only both are categorizing into the same group is probably unlikely. And maybe we are still missing some link so that in future this may be clear. But today, at this time, whatever literature is available, such a transformation is also there. And one is thing, although uncommonly, we do not usually test, but literature says trigeminal evoke potential. These are abnormal in trigeminal neuralgia, but these are not so much abnormalities detected in SUNCT and SUNA. So, although spectrum, why in trigeminal neuralgia, nighttime presentation is there, symptomatology, but SUNCT and SUNA, there is no nocturnal presentation. These things are still unclear to me. I don't know. But to me, spectrum, definitely severity is there. And both are probably different entity. Although initial manifestation is same in both, as both are short lasting and these things presentation. So to me, at present, we can't say that both are same. Probably both are different entities. Spectrum wise, definitely autonomic, this SUNCT and SUNA is severe form, but probably somewhere there is, if there is a anatomical changes due to involvement, then trigeminal neuralgia in which there is microvascular compression, they may also have autonomic manifestation. Otherwise, prominent autonomic manifestations are absent. So, in my opinion, I'll prefer still that both are different, distinct entity.
Okay, one question is from the audience. Why there are nocturnal differences in both these cases? In
I don't
nocturnal,
know. Trigeminal neuralgia, usually nighttime symptoms are also there, but in SUNCT and SUNA, usually these symptoms
is
are not
very
present.
rare. So it marked differences. Unial, you can have an answer for that. Someone has asked why there are differences in trigeminal neuralgia, and nocturnal attacks are more frequent than SUNA, whatever literature are written in there. So your comment for this nocturnal differences?
Sir, I think this is because of the triggerability, because the triggers that trigeminal neuralgia attacks are more easily triggered. So probably in the night time when they sleep, they touch the pillow or the bed sheet, and probably because of that, these attacks are more common in the night also. While in the SUNCT patient, triggerability is not that common, so maybe this is not that evident in those patients.
Okay, Ravi Shankar sir, one more question for you, sir. As we know, trigeminal neuralgia is associated with several other primary headache disorders, sir, with cluster tic, paroxysmal tic, hemikenyan tick. Do you think SUNCT with tick? Some people are just, it is a mixture of both. That's why there are response.
There is a description in literature where they have tried to call it SUNCT and tick associated. But unless the lacrimation extent or the autonomic involvement is severe and the stimulation or the triggering is happening in V2, V3, I would be loath to call it a SUNA tick. But if I face such a patient where the triggering is coming from V2, V3, and the lacrimation is severe with all the features of SUNCT, then I would call it a SUNCT tick and go with carbamazepine as the first drug of choice. And think in that way. Now, at this point, one more reason for difference is why does Gone block work in SUNCT and SUNA and it doesn't work in trigeminal neuralgia? That's a question I have. Second is, how many of you have taken your SUNCT patient to the point of microvascular decompression?
Aliwal, anything from your side?
None, sir. No patient of SUNCT for this. Only one patient we planned for operation, but he is not agreed. So rest all of them are on multiple antiepileptics, and they are still having attacks, but they are better than before. From hundreds of attacks to 4, 5, 10 attacks per day. Trigeminal neuralgias, many patients have been subjected to microvascular, but many of them are actually referred from outside to directly neurosurgery, and then after surgery they are referred to us. So, but we rarely refer patients for microvascular decompression because many of these patients actually respond to drugs very well.
I would beg to differ on that, Vimal, because for me, SUNCT is a difficult entity to treat. So
I was talking about trigeminal neuralgia, sir.
Trigeminal neuralgia is the routine route. It's an easier route to take with drugs and then microvascular decompression. That's a usual route. But I would talk of the neurovascular conflict being reported so often, 40% in SUNCT cases, but they don't land on the table for MVD for refractoriness. So that is the situation, whether anybody has done it and shown the relief, because the literature does talk strongly as one of the measures for refractory SUNCT is microvascular decompression. But in our setting, does that happen is what I would like to know.
Thank you, sir, for a nice discussion. Usually in such type of debate, we used to go for the poll, but initially it was missed. So, but again, we will go for that. What is the opinion of the whoever is participants are there?
Sanjay boss, can I, as a non-headache expert, make a comment? So,
yeah, welcome.
When this topic came, for me, it was like that. Why this debate? We all know that these are the two different disorders. That was my perception. And only what I believed, that only differentiating point is the duration of the attack. If it is, that is what a criteria, 1 minute or 2 minutes, is it trigeminal neuralgia, which hardly lasts more than 1 minute or more than 30 seconds. And if it is more than that, more than maybe 2 or 5 minutes, it is SUNCT or SUNA. But then around 2 weeks back, I saw a patient, and patient came to the OPD with a clearly red eye and tearing from the eye, and clearly before he sat, I thought it is SUNCT and SUNA. Then he described the attack, and this was typically short-lasting pain. And I started on carbamazepine, and the patient is symptom-free now with this carbamazepine. So I initially thought that this was SUNCT and SUNA, and it was in the V1 distribution pain. So now, after hearing all these things, and then I also do believe that probably these are the same disorder of the same spectrum with probably different manifestation and different severity. Clinically, I think if there is a doubt, you go for the carbamazepine in the initial part, and then if doesn't work, you can use lamotrigine. Somehow, clinical neurologists, all the general neurologists are a bit reluctant to use lamotrigine not even in these pains, but otherwise in epilepsy also. So that may be one thing that lamotrigine may be more frequently used as if it is not responding to that. And I don't see if there is a microvascular compression, whether it is clinically trigeminal or a clinically SUNA. If patient is refractory, I think I would offer a microvascular decompression. That will be my take as a purely as a non-headache expert.
Okay. Can we go for poll here? Just see the can we ask for that from host side?
Yes, sir. I'm just doing that.
Yeah. So just requesting to all participants, just give their opinion in this regard. After listening experts, panelists and speakers.
Yes, so only 8 people has voted. And
only 8 people.
Yes, 9 now, and it is 5 and 4.
So confusion is equal, 50%.
So we debated well, I think.
Yes, I think both debated well. At least they gave out
So-
all the information which is useful for us for the next patient we see.
So thank you, sir, for being here, everyone, sir. And you just is there, sir. It is just important thing, sir. Just the 64 and 36, but both are separate disorder. So Rathod, Chaturvedi, yours say here, and just final point from your side.
No, this regarding this debate, I have shared my views, but I would like to thank Ravi Shankar sir and all the Vimal, Ravi, and Dr. Ajay for this talking on this session and wonderfully presenting different views. And obviously, unless probably we see more cases and there is some further details come out, this debate will go on. But definitely, we have come out with some clinically useful tips which can be helpful in managing the next patients. So I thank you, all of you, for joining and enlightening all of us. Thank you very much. And I thank you, all the delegates who joined for this. We apologize for the initial some technical hiccups, and I think we'll take care of this in the future. I also thank Estera Division of INTAS and Mr. D'Souza, Dr. D'Souza, for helping and supporting this academic endeavor. So with that, I think we can end the session. Thank you very much.
Thank you, sir.
Thank you,
Thank you so
Chaturvedi,
much.
Sanjay.
Thank you very
Very
much.
interesting
Thank you, sir.
topic. Thank you all.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank
So
you.
thank you very much, sir. Thank you very much. Good day.
Good day.
Yes, sir.
Hello?